topic for today is patient-specific subperiostal implants, the prosthetic part. So we move on with the next lecture. Dr. Arshad, please go on. Is she on?
Hello, everyone. Thank you for having me. I'm Dr. Mahnaz Arshad, orthodontist and Associate Professor of Tehran University of Medical Sciences. I'm going to be speaking to you today about the subperiostal implant, especially prosthodontics parts. صدای من دارین؟ خوب هست؟ هست؟
Yes, we do hear you. Please move on.
So, okay.
On mute, thank you.
Okay. Okay. Everybody knows about the implants. Today, goal of modern dentistry is restore normal contour and function, comfort, aesthetics, and dental implants help us today for this reason and for these goals. But in some special situation, when we have an atrophic ridge or when the nerve is near the crest, we can use as a usual endosal implants. So that's the challenging today to restore these people and to help these people. And in some years before, some subperiostal implants were used, but they didn't have any good results. And today I want to talk about that, why they didn't have any good results, and what's the new things about subperiostal implants that we use today and have a good result. We have three types of dental implants. Transostal implants, that's a very early implants, subperiostal implants, and endosseous implants. And today's usual implants that we use is endosseal implants. But subperiostal implants is in some occasion, for example, in trauma, in cancer, in a patient with long-term edentulous jaw, that we haven't enough bone, we can use subperiostal implants. If we want to introduce the subperiostal implants, we must say that a subperiostal dental implant is a framework that use the retention from around the bone, not in the bone. And in primary subperiostal implants, it's the material is chrome cobalt, and they use the castable procedure. So the shrinkage, the material, the procedure is somehow makes some bad results. So we put away the subperiostal implants. But nowadays, we have another method, the digital revolution and the 3D printing and the SLM and CAD/CAM. New processing software that we use, for example, we use modern digital software, some special software, for example, Materialist 2, and we have a CT and 3D CT or CBCT 3D, so we can have exact subperiostal implant from titanium alloy 23. So the procedure is very precise, and we can rule out the problem that we have with subperiostal implant in the past. So in new generation subperiostal implant, the survival rate is so higher, and we can help the people that don't have any sufficient bone. Titanium grade 23 is biocompatible. It's so biocompatible, and the ultimate strength is 920 megapascal. That is so good, and the elasticity modulus is near the bone, and the fatigue strength is so good. So the behavior of material is special and good for the purpose of us. And the framework design, as you see in the picture, in previous subperiostal implant, they directly on the alveolar crest. But in new subperiostal implant that we use nowadays, they surrounded the bone and use the symphysis and the buccal external buccal oblique ridge, so the retention, the osseointegration is so high, the mobility is less, and the fixation is so higher than the previous subperiostal implants. So we have the better result, very better, a very better result. Okay, if we don't have subperiostal implants, if so many years that we don't use subperiostal implants, we use short implants for such patients, or we use zygomatic implants. We use onlay graft, or we use nerve repositioning methods, or we use alveolar distraction or osteogenesis. All of these procedures have some limited survival rate, have some side effects. For example, short implants, when we use short implants, the bone resorption, the crusher bone resorption, the stability may be questionable. And also in some patient with very bad ridge resorption, very severe ridge resorption, we can't use short implant. We can also use short implant. Or zygomatic implants have needs a very great surgical procedure, and the surgeon needs to put the implants in a special site, and the patient needs to have some bone in some area. So we have some patients that they don't have any sufficient bone in that area, and they don't want to go under this heavy surgery. Onlay graft is another method, but the resorption is the problem, and the successful and survival rate is questionable. Many implants in onlay graft, they failed because of the bone resorption. Another way is nerve repositioning, and these method for the mandibular jaw is questionable too, because many patients have anesthesia, paresthesia in the lower jaw, and it's a problem for the patient. It's a great problem for the patient. And another way, alveolar distraction osteogenesis, it's a very heavy procedure. We can control the plan of occlusion very much, and it's so hard. Especially, it's a very hard way in a old patient, and especially our many of our patient is old, in old age. So subperiostal implant is another way that can take place of this procedure. And I do this procedure about 5 years, so I can talk about the survival rate in 5 years. But other article that other people that work in subperiosteal implant and published the article, they said that's a successful method, and survival rate is 79%, 87%, and that's good. That's great. Subperiosteal implants have some clinical complications such as infections, early and late implant exposure, bone resorptions, maybe absence of osseointegration, fistulation, implant mobility, patient discomfort, and implant failure, pressure necrosis, failure of many subperiosteal implants like the other endostal implants. And it's not a new things. We have some failures in endostal implants. But with the subperiosteal implants, we can help people that they can't have a teeth. They can't have any mastication with the usual implants. And they don't want to be undertaken the large grafting procedure and using the iliac bone graft and something like this. So it's helpful for these people. Manufacturing for subperiosteal implants is nowadays is pure digital. We use virtual modeling on CT data and then making the subperiosteal implant with titanium grade 23 with SLM devices, with 3D printing methods, and finishing, polishing, and then use the surgery with some special guides. And the prosthodontic procedure is also pure digital. So the mistake is came down. For framework, we have fully edentulous or partially edentulous patients. So we must determine and make the framework especially for that patient, especially suitable for that bone anatomy and structure. If you see the picture, in a framework design, we have one pieces or segmented framework design. For mandibular, it's better it's be 2 pieces, and for maxillary 2 pieces too, because the seating of the framework is more easier when it's 2 piece instead of 1 piece. In a framework, we have the wings that we screw the subperiosteal instead of the whole of the wings. We have the basal loop framework and the arms and the post. And the post is the place that we connected the crowns or bridge and prosthodontics to the subperiosteal implants. The overall structure of the subperiosteal implants must be 1.5 up to 1.8 millimeter thick, and not more 1.2 or 5.3 more thicker, because if it's so thick, the dehiscence make the dehiscence we see the more dehiscence. So it's important that we make the subperiosteal implant in a very thin shape. And the wings, nowadays the subperiosteal implants have shorter wings with 2 holes. One hole is sufficient, and another hole is the backup of the first hole if the threads have a problem. And you see the arm is a very sensitive part that you maybe have the stress in it, and maybe you have the breakdown. So when we design the subperiosteal implant, it's important that we straighten these parts. And the base of framework design is up to the bone. It consists of loops. It consists of loops because if you want to separate the one segment of subperiostal implant is more easier that you can separate it. And some special place that the surgeon can screw the subperiostal implant in the bone. And after we make the subperiostal implant, polishing the perimucosal extension is so important, because if you have any dehiscence in this area, it must be polished very well, because the plaque, we don't want to the plaque attached to this area, and the patient can clean it, this area so easily. And we have different kind of post, different model of post, and I show you the different model that you can choose in your patient, that what kind of these abutment or what kind of these posts you can select. In a manufacturer, the subperiostal implants were made with additive manufacturing, and the method is SLM, because it's metals, and EBM, DMLS, SLM, 3 different methods that they make subperiostal implants, but SLM, that's one that we use in Iran. And this is the device that we use to make the subperiostal implants. The material is titanium grade 23, and it's have high strength to weight ratio, perfect fatty behavior, and outstanding corrosion resistance, and biocompatible. It must have complex geometry, porous structure, and it must be cost efficient in small quantities, and variant mechanical properties and high accuracy, up to 13 micrometer. For the procedure, at first, surgeon requests the patient to go and take the CT scan. So we see and check that it doesn't have enough bone. And then we make a surgical stent, and then the patient take the 3D CBCT or 3D CT, and then we design the subperiostal implant up to the patient jaw or patient ptosis, and then after the prosthodontic surgeon approve the design, it's printed, and some surgery guide maybe they make some surgery guide to put the printed subperiostal implant, and then we take scans of that, then go to the cleaning room, and then the patient was under surgery, and after 3 weeks after surgery, we can deliver the temporary crown, and after 3 months we can deliver the final prosthesis. The sterilization of subperiostal implant is with gamma or autoclave B or ethylene oxide. For prosthetic design of the subperiostal implant, we have 4: ball design, connecting bar, connection design, and abutment level. Ball design is the primary feature of subperiostal implant. And we have some problem with this kind of feature, because the roughness of the ball, because the ball made with the casting procedure, and the wear of the balls after somehow the patient use it, the wear of the ball make the retention so decrease, and the parallel of the ball is is another thing that must be so important, cap retention and dimensional accuracy, because when we printed the ball, after the printing procedure, they sandblasted and the polishing. So the ball, so this procedure make the ball so smaller. And we don't have the exact size, so the retention is the problem. You see the patient that we use the ball in this patient. The patient come to our office with the mandibular breakdown, left mandibular breakdown because of the severe atrophic ridge. And we design the subperiostral implants with the ball type shape and the ball type for the retention of the prosthesis and the structure for the stabilizing the broken jaw. And you see it's a kind of overdenture that we make for her, but the retention of the ball after 3 years is the problem for us, because some ball is weird, so the cap is not suitable for that. Because of that, I don't like so much the ball type of the subperiostral implants. Another category of the prosthodontics features of the connecting bar. Momart, Mr. Momart, and the one that do the subperiostral implant so much that likes the connecting bar. And you see in the picture how he used it. He put the subperiostral implants and some pose, and after that they make the bar and they deliver the prosthesis as a screw retained prosthesis. Something like the hybrid prosthesis. Another model is connection design, that they make the connection of the implants in the post of the subperiostral implants and use some impression coping and abutment like the endostall abutment implants for them. But the so important thing that you must pay attention on it is for the length of the connection, you need to have some height of the post, and in somehow we can't use it because the post came out of the mucosal and it's makes it's not satisfied the patient, that when you see you have the some grayish metal on his mouth. And also the connection must be very precise, and the abutment is can connect it to it very fit. So it's another problem. The last design, it's my design, is abutment level subperiostral implants. I like it so much. It's so hard to design it because you must design the abutment before the patient go to the surgery room. So everything must be exact because after that you can change the degree of or length of the abutment. So you must see the end stage of the prosthesis in the first stage. But if you do it in a very exact way, instead it's hard, but at the end I think it's better. It's more easier. I can show some patient to you that you see my design. Partial edentulous that you see in this patient. In this patient we have class 1 Kennedy. We don't have any tools. Excuse me. We don't have any tools. Both sides of distal extension of the jaw, and you see the nerve is up to near the crest, and the patient don't wants to have any anesthesia or paresthesia, didn't accept any risk of the paresthesia of the nerve because of their nerve repositioning. So we decided to did this to make the subperiostal implants for her. We make some surgical stent, special surgical stent, and take some CT, 3D CT. So we designed the subperiostal implants for her, as you see. And you see, for subperiostal implants, at least you need 0.8 millimeter of cortical bone. So we can do it for many patients. And you see the subperiostal implants that's ready. The patient go to the surgery room and did the surgery, and you see the subperiostal implants in her mouth. And after that, we prepare and make the prosthodontics, and you see the patient have 3 years follow-up, and you see the radiographic of the patient, and it's good. We satisfied of the result of this patient. This is another patient, and the man have the Edentulous Kennedy class 2. And you see, it's we have a resorption of the jaw so much, so we can't put in the soul implants without any paresthesia or anesthesia of the jaw. So we decide to put the subperiostal implants. So we make some surgical stents. We put the sulfide barium just on teeth, not on the base, because we want to have the crest of the base on the CT. And we designed the subperiostal implants upon of the surgical stent that you see in the picture. And that after that, we printed the implant and we do the surgery and we deliver the prostheses. It's have a 1 year follow and it's good. We have the good result. Another case is full mouth edentulous, and you see the patient that have previously had some endosal implants, and then implants was failed, and he lost all of his bones, and he was just 25 years old. He's so depressed because he hadn't any teeth. So we decided to make the subperiostal implants for him. You see the 3D CTs of him. We designed the subperiostal implants in 2 parts for a maxilla. Abutments depends on the surgical stents. As you see in this schematic view of his jaw, the subperiostal implant, the stents, the lateral view, and after that we printed the implants. You see the polished surface, the sandblasted surface of the subperiostal implants. The temporary also we make the temporary before he came to the surgery room. After he went to the surgery room, the subperiostal implant was screwed in the on the maxilla, and you see the healing of the implants. Just we have one side dehiscence in a right maxillary. It's not so important. You see the pose, the abutments, and we delivered the. We also delivered the temporary for 3 months. The sitting is so good, so easy. And after 3 months, we check the framework. We didn't take any impression because we have the files before he went to the impression surgery room. And you see the final prosthesis, and that is the smile view of the patient after we deliver the prosthesis. We have the 5-year follow of this patient, and it's good. Just the right side of the dehiscence of the right side of the maxillary, and that's not important for this patient. We check it. You see the radiography of the primary phase, temporary phase, and the final restoration. This is another full mouth reconstruction case that you see. We have the patient, fully edentulous patient with a very resorbed ridge. And the patient is so depressed because he just 28 years, he was 28 years old, and he wants to have a aesthetics, also have a mastication. So we make the surgical stent, we catch the 3D CT, and we design the structure, the subperiostal implants upon the surgical stent, and they were printed. The subperiostal implants. We put it in the surgery room, and this is the final result of the patient. You see, we have some dehiscence in the lower and upper jaw, but the dehiscence is in polished perimucosal area, so it's okay. Okay, in a very large subperiostal implants, we maybe have some dehiscence, but when the dehiscence is in polished area, the patient can clean it, and it's the maintenance is not so hard. This is another full mouth reconstruction patient, just for the mandibular reconstruction. The patient came to our office from Canada. The woman about 67 years old, and you see the resorbed mandibular jaw. We make the stent and catch the 3D CT, design the subperiostal implants, and also change the upper jaw crown. And you see the final result of hair, just two sides of the dehiscence you see in a lower jaw. But the radiography, when you see, it's good. This is the picture of the patient, the pre-treatment and after treatment picture. And this subperiostal implant is so useful and so special in tumor excision patients. And I put the two cases of tumor excision. The first case is the man about 48 years old, and he caught the ameloblastoma tumor in the right side of the mandible. And many doctors said to him, and you must section your jaw, and your face is changed. And after that, you can go and rehabilitate or reconstruct with some plate and put some removable prosthesis. But when he came to our office, we offer him subperiostal implants, and we designed the subperiostal implants up to his 3D CT. You see the CT of the patient with the severe ameloblastoma, and you see the exoda on the intraoral photo. We section the jaw up to how we want to section the jaw in a surgery room, and then we design the plate and also the abutments as a subperiostal implants, and we design the abutment up to the teeth that he had in his mouth. And after that, we printed the abutment and make the temporary crown before he went to the surgery. After the surgery, we delivered the temporary crown, And after 3 months, the patient came, we check the modeling wax, printed modeling wax, and then we deliver the final prosthesis to the patient. We have the 3 years follow-up of this patient, and it's good. Another patient is a patient of a history of amyloblastoma, but he was surgery so 2 years ago, and he came to our office with this shape of his jaw, and she wasn't satisfied with the appearance, and she was also she also wanted the aesthetics and the masticatory solution of his mouth. So we designed the sub-periosteal implant. We make some surgical stent and she take the 3D CT, and we designed the sub-periosteal implants. And with the sub-periosteal implants, we tried to make the chin corrected. But something is important, that it's because of the scar of the tissue, we can't protrude the sub-periosteal implant so much because it's made some dehiscence there. So we deliver the sub-periosteal implants, as you see, and we check the modeling resin, and then deliver the final restoration, and this is the satisfaction of the patients. We corrected the chin, but the correction more of the chin maybe with some prostheses, not with the sub-periosteal implants, but she could masticate with these prostheses. So she's satisfied. I delivered this patient before the Nowruz holiday, the last day of the span, and she was so happy and so thankful, and it's the great time of mine. I have the movie of how making sub-periosteal implants. Maybe you want to see these. This is of the patient, the man that have amyloblastoma. This is the procedure of the surgery and putting and screwing the sub-periosteal implants. I want to thank to everybody that hear me.
Thank you so much, Dr. Arshad. It was great, quite very amazing.
Thank you very much. Thank you too.
All right, Dr. Arshad, thanks a lot for the wonderful presentation. I'm sure that we have a lot of questions here. Let me start by myself, and then we see who has question. As far as the number of abutments in different situations and the height of the abutments, what are your preferences and how do you recommend that?
The height and the number of the abutments is just like the endostall implants, and I designed the abutments like the situation that I have the endostall implants. The abutments is any extension, and the abutments in a key points, for example, in the molar side, in the canine side, in the first central and the first premolar size. But the point, the key point of the abutment is it's not, they aren't being so near because it makes so dehiscence. At least we must have 6 millimeter distance between one abutment to other. And the 6 or 7 millimeter distance between abutment and the bone, especially in a tumor excision. In a tumor excision, you must put the 6 millimeter distance between the level of the abutment and the bone, because the abutment is so deeper than the crestal bone, and if we don't have pay attention to these, after the surgery we can't insert the prosthesis. So we must pay attention on the distance of the abutment and the height, because in this way, for example, in very resorbed crestal bone or in excisional, in tumor excision, we have very long abutment. I don't make the abutment longer than 11 millimeter, because many long abutment make the insertion of the prosthesis so hard. So these key points is not written or not written anyway. It's our experiment in, for example, in I think 35 patients. Maybe we can publish it in next years if the patient come more, and for example we can publish the review of some patient and publish the result, and other scientists have some give us their opinion about these things. But the experiment of me is that.
Great. So we are looking forward to have more articles from you in international
Thank you very much.
Journals. So another question regarding, you mentioned at one point, we do have titanium and chrome cobalt part. Is it in one piece of periostral implants, or it comes in, it depends on the patient or situation? Could you hear me?
No, excuse me. Could you please repeat? I don't have your voice. Okay. Could you please repeat the question? I think you will stop. Pause. The moderator was.
Sorry, it seems that we lost the connection for a second. So if you don't mind, pardon me, could you answer the question? We had the lost connection here.
Could you please repeat it? I can't hear.
You don't have your voice.
Could you please repeat the question?
Dr. Asha, can you hear me?
Yes, now, yes.
All right. So there is another question coming up regarding the software that you use to design the framework.
Okay. Okay.
Go on, please.
Okay,
One of the audience, Huria, asked the software.
Okay, I didn't hear very well. You asked me about your software that
Right,
we
that's
design.
correct.
Yes, we use materials for designing the periostal implant. That's some engineering software for designing.
Great. And then another question is regarding the immediate loading. I saw for the most of the cases, you had this option to deliver a provisional restoration for the patients at the day of the surgery, which is very great. And you satisfy the patient with the result from the very beginning. So is it very common? Do you usually prefabricate the provisional restorations at the stage of framework design, and it's ready to deliver at the day of surgery?
Yes, you know, in the abutment level design, because we have some long abutments, some abutment in the patient mouth, if we don't deliver the temporary, it's annoying the patient. The abutment maybe make some discomfortation for patient. So we have an option to deliver after 3 weeks. We deliver the temporary crown. Maybe some patient didn't want or didn't accept, but in most patients we deliver, and it's so good because they came back, especially in a tumor excision, they came back to the routine life the day after surgery, and they are so satisfied because in tumor excision they think after the surgery they miss their appearance, their ability, and their jaw is so canted, so canting. So if we deliver the temporary crown, they came back to their normal life easily and rapidly. So have a very good psychological effect and also physiological effects because they can eat easily. And if we don't deliver the temporary, the tongue, especially the tongue is some annoyable. It's they are not comfortable with the tongue and the abutment.
Right, right. Yeah, that's obvious, that because the abutments are very sharp and long, so it bothers the patient, and it does help the patient for chewing as well as protecting the tongue. So
yeah.
It was a very nice topic since
Thank you very much.
I'm prosthodontist too, so I would like to ask a question regarding the fully edentulous patients that you provide prostheses for them. And you mentioned that you made the prostheses ready ahead of time. So regarding that cases, did you have any issue regarding the occlusal plan and the lip support? How do you design that critical points for that patient?
Okay. For the edentulous patient, we do all the thing in a first stage before the surgery. If we make the surgical stent, as we make we make for them the complete denture. We analyze and determine the lip support, the occlusal plan, and after that we prepare the teeth and we check it in the patient mouth, and then we make the surgical stent. But the special point of the periostal implant is the abutment must on the crestal bone, not very far from the crestal bone. So as you see, for example, in my patient, in a man, the complete edentulous patient, we can't make the profile, we can't bring the profile so forward, because if we forward the periostal implant, it makes some dehiscence. Maybe in some occasion, the overdenture had so better aesthetic appearance, but many patients don't want the overdenture, they want the fixed prosthesis as they are so young. So that the point we must pay attention on the subperiostal implant is we can't make the profile so forward. We can't correct the profile so more. Just for example, for 5 millimeter, 6 millimeter, we can compromise the profile, but not so much. So every patient come to my office, I said to him, if you want to correct your lip profile or your nasolabial line, we can do the subperiostal implants. You must go and put the, for example, 4 implants and do as an overdenture. That is, but before the surgery, before we make the surgical stand, we determine the lip line, the occlusal plan, as we can do, and show the patient, and patient said okay to us. And after that, we make the surgical stand, and he put the stent and take the 3D CT, and then with that CT and the position of the teeth, the engineer designed the abutment post, and so we have the occlusal plan, the lip line, the profile, and the implant, also the implants. So just we must make some small correction in a definitive prosthesis.
Great. So as far as my understanding, as you mentioned, you provide a full denture for a fully edentulous patient, and that would be your reference point for lip support and the vertical dimension of the jaws, and you duplicate that denture for